Good morning, everyone. So, my next video, which I'm going to discuss with you, is on the topic excretion in the pharmacokinetics. It consists of pharmacokinetics, as you know, it consists of absorption, distribution, metabolism, and excretion. In this video, I'm going to discuss with you excretion with you. And before I start my video, I want to request you if you like this video and if this is helpful to you, kindly subscribe to my YouTube channel. Let's Dr. Nitika Pharmacology Discussion. Thank you. And now, before now I'm going to start my video on excretion. Now, roots of drug excretion. What are the roots of drug excretion? These can be kidney, liver, lung, GIT, milk, bile, saliva, and skin. Means from all these organs or these body parts, the drugs they can be excreted. Like kidney is the main organ of excretion, followed by liver, then lung, GIT, milk, bile, and saliva and skin. Now, kidney is the most common of our drug organ of excretion for majority of the drugs. And what it excretes. It excretes inactive water-soluble substances. Now, first of all, before starting this, I want to discuss with you what is excretion and what is elimination. Elimination is metabolism and excretion. It is a process by which the drug it gets inactivated in our body and then it is excreted out. That is elimination. And excretion of water soluble substances, inactive water soluble substances from our body is the excretion. Now, excretes water soluble substances, three phenomena which are involved, that is glomerular filtration. In the glomerular filtration, this is the drugs they get filtered out from the glomerulus, which has the pores or fenestrated pores in the membrane, which pass out the water soluble substances as well as the lipid soluble substances. Tubular reabsorption. This is how the drugs they get reabsorbed from the tubules to the peritubular capillaries. It gets reabsorbed, tubular reabsorption, and it depends upon the lipid solubility and pH of the drug. Tubular reabsorption. Means if it will be more lipid soluble, more it will be tubular reabsorbed. And pH, if it is opposite, then it gets ionized. Like if the acidic drug is there and we alkalize the tubules, so it gets ionized and it gets water soluble and it is excreted out. But if the medium is acidic in the acidic drugs, it becomes non-ionized, it becomes lipid soluble, it can be reabsorbed from the tubules to the peritubular capillaries. Tubular secretion is how the peritubular capillaries secrete the drugs in the tubules, and that is through the pumps. Tubular secretion is through the pumps. Various pumps like P-glycoprotein pump is there, ABC binding cassettes and solute carriers, and organic cation transport and organic base transport is there. And net excretion is how tubular filtration that is out of the body, tubular secretion that is out of the body, that is in the tubules, the drugs are secreted, and tubular reabsorption is from the tubules, the drug are reabsorbed back in the peritubular capillary, so it will be minus tubular reabsorption. Now, glomerular filtration, they have the pores, I have already told you. Both the lipid soluble as well as the water soluble substances, they can pass through it. But it depends upon the plasma protein binding. Means more will be the plasma protein binding of the drug, so more will be the size of the drug. And when the size of the drug is more, so it will be less filtered out. Means plasma protein binding is less, more filtered out. Plasma protein binding is more, less filtered out. Renal blood flow, more will be the renal blood flow, more will be the glomerular filtration rate. Normal GFR is 120 milliliter per minute. And what is tubular secretion now? It is from the peritubular capillaries to the proximal convoluted tubules, loop of Henle, distal convoluted tubules. Means the drugs, these are passing from the peritubular capillaries to the proximal tubules. And it is the bidirectional. There is organic anion transport and organic cation transport. Tubular secretion, I have already told you, takes place by the pumps. So it will be organic anion transport, organic cation transport at the proximal tubules, P glycoprotein and MAP2. These are located in the luminal membrane of proximal tubules. Now, this organic anion transport is the for the acid, means acetic drugs. These are transported from the peritubular capillaries to the tubules, like penicillin, propionic acid, uric acid, salicylic acid, indomethacin. Means these are the acidic drugs and they get transferred from the peritubular capillaries to the tubules. Organic waste transporters. The basic drugs, organic cation change transporters. The basic drugs like thiazides, amyloids, trimetharin, furosemide, quinine, these are transferred from the peritubular capillaries to the proximal tubules. Tubular reabsorption, this is the second step, that is from the uh, tubules to the peritubular capillaries. It is a bidirectional process and it depends upon drug concentration gradient. Means if more will be the drug in the tubules, it will be passed out into the peritubular capillaries. Lipid solubility, if it will be more lipid soluble, more will be the passage of the drug from the tubules to the peritubular capillaries. And lipid solubility can be in the non-ionized state. Means if the drug is acidic, the medium should also be acidic in the tubules. So it will be more lipid soluble, non-ionized, and it will be passed from the tubules to the peritubular capillaries. pH, I've already told you, acidic pH and alkaline pH, they are ionized, they become water soluble, drug becomes water soluble, it is excreted out. But if the pH is same, acid pH and the acidic drug is there, that becomes non-ionized, it becomes lipid soluble, it is reabsorbed back from the tubules to the peritubular capillaries. Acidic drugs are better excreted in alkaline urines. I've already told you. And alkaline drugs are better excreted in acidic urine because these drugs they get ionized in the opposite medium, then they become water soluble and they are excreted out. The same thing. Acidic drugs like barbiturates, salicylates, we alkalize the urine and drugs will be ionized, water soluble, reabsorption will not take place and excretion will occur. Alkaline drug, we acidify the urine. How we alkalize the urine is we add the sodium bicarbonate, and how we acidify the urine is we add ammonium chloride. Drug will be ionized, water soluble, no resorption, and there will be excretion of the drug. But acidosis can induce rhabdomyolysis and cardiotoxicity, so it is not pectized. So next is normal GFR is 120 milliliter per ml per minute. So if the clearance, now they say if the clearance, that is the how much drug is inactive drug is excreted out of the body per minute, per unit time. If clearance is more than 120, it means the tubular secretion is also present. Means there is active tubular secretion. And exogenous substances, they are basically the tubular secreted like drugs in the tubular lumen. And endogenous substances like uric acid, they are reabsorbed from the tubular lumen. Endogenous are reabsorbed, exogenous are excreted out in the tubular secretion. And tubular reabsorption and tubular secretion are sites of pharmacological intervention. Remember, tubular reabsorption takes place from tubules to the peritubular capillaries, and tubular secretion takes place from peritubular capillaries to tubules. Now, in renal damage, what happens is there is reduced capacity to excrete the drugs, so there will be accumulation of drug and there will be prolonged action or toxicity of the drugs. When renal damage, excretion will be reduced, GFR will be reduced, tubular secretion will be reduced, renal blood flow will be reduced. So that will lead to accumulation of drug in the kidney and in the body, and this will lead to prolonged action and toxicity of the drugs. So avoid drugs like potassium salts. They may cause hyperkalemia and aminoglycosides and cumular anticoagulants. Now propionic acid. Now this is the organic acid which has high affinity for tubular anion transport. Uh, tubular anion transporter means it has this pump is there And this propane acid has the higher affinity than the drugs for this pump. So blocks the active transfer of both penicillin and uric acid. How? That will be discussed now. How? Penicillin, as penicillin is the exogenous substance, so it will be tubular secreted. Okay? It is exogenous substance, so it will be tubular secreted. So it will be excreted out. Propane acid, which is the organic acid, which has higher affinity for the organic anion transport pump, it will prevent the tubular secretion. And when the tubular secretion is prevented, it will lead to retention of penicillin in the body. That will lead to more effect of the penicillin in the body, which is the beta-lactam antibiotic. Uric acid is the endogenous substance which undergoes tubular reabsorption. So propane acid, again, it has the higher affinity for the pump, organic anion transport. So it will inhibit the resorption. And when it inhibits the resorption, it leads to excretion of the uric acid from the body. So in gout, we give the propane acid with uric acid so that uric acid gets excreted out. Sorry, we get propane acid so that uric acid of the body, it gets excreted out and the gout is prevented. Now, what is the effect of age? Infants, the GFR and tubular secretion, the organs of the kidney, they are less developed. So GFR is reduced, tubular secretion is reduced, renal blood flow is reduced. So there will be decreased clearance, and that will be lead to increased plasma levels of the drug. Elderly also, the GFR is reduced, tubular secretion is reduced, renal blood flow is reduced, clearance is reduced, so increased plasma levels. Intestine, some drugs are unabsorbed, excreted in pieces as such. So some drugs, they are unabsorbed and they excreted in pieces as such, like streptomycin, neomycin, cholestyramine. These aminoglycoside and bilysis cholestyramine. It is uh, unabsorbed and excreted in pieces as such. Some drugs are absorbed from GIT and then from bloodstream gets excreted back in gut, GIT. With some drugs, they're absorbed from the GAT and they reach the bloodstream and then they seated back in the gut. Now, enterocytes, which are the cells present in the intestine, they contain P glycoproteins. They take up drugs and metabolites from the blood and they secrete them in the intestine. Passive diffusion process occurs. It transfers drugs and metabolites from the blood, secrete them in the intestine. Senna and cascara, which are the drugs for the constipation. Senna and cascara are absorbed from intestine, enters the bloodstream, and secreted in colon. Heavy metals are absorbed from intestine, enter the bloodstream, and secreted in colon. Now some drugs are expelled in the expired air, like volatile general anesthetics like halothane, isoflurane, sevoflurane, desflurane, ether, nitrous oxide. These volatile general anesthetics, these can be expired out in the air. Now, entry through inspiration, exit through expiration. Alcohol, only 5% of alcohol is secreted in the expired air, and so not important from pharmacological or medical point of view. But for the medico-legal perspective, presence of alcohol in breath, which is 5%, stands as a person has jumped legal boundary. Means the person is alcoholic. To check that the person is alcoholic or not, we can test for the expired air, and presence of alcohol will be against the medical legal perspective. Paraldehyde, it can be excreted by the lung. Skin, arsenic and heavy metals, they get excreted in the skin. Arsenic is deposited in hair follicles also. Milk is the lactating mothers. They feed their infants a drug administered to mother. They feed their infants, and when the drug is administered to these lactating mothers, they enter the breast milk, reaches breastfeeding infant, and may produce effect on the infant. So drugs enter breast milk by passive diffusion. They enter breast milk by passive diffusion. Lipid soluble and less protein bound are better concentrated in milk. Less protein bound means they are smaller in molecular weight, and more lipid soluble, more absorbed, more easily pass through the membranes. They're better concentrated in the milk. And basic drugs are more concentrated. Why? Because the pH of milk is 7 and pH of plasma is 7.4. So it is pH is acidic. And basic drugs, they will get ionized in the acidic medium and it will become water soluble and it will be secreted in the milk. So they are more concentrated in the milk. pH of the milk 7, pH of plasma 7.4. So milk is slightly acidic. Milk is slightly acidic. So only unbound drug can enter the milk. Means plasma protein binding should be less. And unbound drug can enter the milk like warfarin who has high plasma protein binding cannot be excreted in the milk. And usually drugs entering the infant through milk are harmless. Usually the drugs which are entering the milk through the infant entering the infant through milk, they are harmless because they are in very small quantities and they do not affect the infant. In infants, slower elimination accumulation may occur when baby receives it with frequent breastfeeding. Means when the baby is receiving the breastfeeding from the mother and frequent breastfeeding is being done, so they can lead to accumulation of the drug because elimination is less, but accumulation can occur because of frequent breastfeeding. Now, what is clearance? Clearance is volume of plasma that is cleared off in unit time. It is milligram per kg per minute. It is expressed in milligram per kg, sorry, milliliter per kg per minute. Example, clearance of drug is 2 milliliter per minute, which means once drug is distributed in the plasma, every 2 milliliter of plasma will be cleared from the drug. So after 1 minute, 2 milliliter of plasma will be cleared of the drugs. See like this. Suppose the plasma is 110. These are the 110 units or the squares. And 1 square is 1 ml. Now if clearance is 2 milliliter per ml, so then after 1 minute, 2 milliliter will be clear like this. After 1 minute. After another 1 minute, again 2 milliliter will be cleared. After another 1 minute. After another 1 minute, again 2 milliliter will be cleared. And so on. So after 55 minutes, plasma will be completely cleared, but because all 110 squares will be cleared, plasma will be completely cleared after 55 minutes. Now, what is first order kinetics? Basically, you have to know that first order kinetics, these I'm going to discuss with you. These are these are kinetics of elimination. First order kinetic is when constant fraction of the drug is eliminated. Means rate of elimination is directly proportional to plasma concentration. Rate of fraction is directly proportional to concentration. Elimination falls. Rate of elimination falls. Concentration falls. Means constant fraction is being excreted out from the body. This is first order kinetics. Rate of elimination is directly proportional to plasma concentration. And clearance. What about clearance? Clearance is constant in the first order kinetics. Clearance is constant in the first order kinetics. Why? Because the rate or the constant fraction is being eliminated, so clearance will be constant. Now, zero order kinetics is when constant amount is being eliminated. Like some drugs in the low dose, they are following the first order kinetics, but in the high dose, which in the saturable kinetics, they follow the zero order kinetics. Why? Because enzymes like alcohol dehydrogenase saturation can occur. So on continuous intake, concentration increases because metabolism remains the same. Metabolism will remain the same. Some drugs, enzymes may be saturated, Metabolism remains the same, but as we increase the dose, it gets accumulated in the body. So then when it gets accumulated, only constant amount will be eliminated from the body, so it will follow zero order kinetics. Now alcohol, it follows a zero order kinetics, and phenytoin, salicylates, tolbutamide, and alcohol, phenytoin, aspirin, warfarin. These drugs, they follow zero order kinetics. And this rate of elimination in this case is constant. In the zero order kinetics, rate of elimination is constant. And clearance. Clearance in this case is inversely proportional to plasma concentration. Clearance in this case is inversely proportional to plasma concentration. Means more will be the clearance. Means if the plasma concentration will be more, clearance will be less. If the plasma concentration slowly reduces, clearance will be more. So clearance is inversely proportional to plasma concentration. Now half-life. What is half-life? It is the time taken for the circulating plasma concentration of the drug to reduce to 50%. Means when half-life is, it is the time taken, how much is the time taken for the drug in the plasma concentration to reduce to its 50% of the amount. What is the time taken? That is half-life. And duration of half-life is determined by rate of clearance. Means if the elimination is faster, shorter will be the half-life. Elimination is faster means we are excreting the drug more with rapidly. So half-life, the time taken to reduce the drug to its 50% concentration, that will be less. Shorter will be the half-life and faster the elimination. Widely distributed drugs have longer half-life. Means widely distributed drugs to the tissues, they will have the longer duration of action, so longer half-life. Plasma protein binding. More will be the plasma protein binding, more will be the action of the drug in the body. So half-life will be more. Now, what is the half-life? What is the importance of half-life? It is to know the duration of effect. To know the duration of effect means how much is the duration of effect in the body, and also the dosage schedule means if the half-life is less, the dosage schedule, the frequency will be more. Frequency of dose administration will be more. If half-life is less, frequency will be more. And if half-life is more, frequency will be less. If half-life is less, frequency will be more. If half-life is more, frequency will be less. Now, loading doses, when we give the drug, sometimes to produce the effect of the drug, we have to give the increased dose in the beginning. We have to give the increased dose in the beginning to produce the effect of the drug. And like in osteoarthritis, the painkiller is given at the highest dose which for the required to reach the 4 half-lives, so that it reaches the steady state plasma concentration. So a larger dose which is given uh, in the beginning to produce the effect, that is loading dose. And plasma concentration is reached after 4 to 5 half-lives. And delay doesn't matter if half-life is short. If therapeutic plasma concentration required immediately, give loading dose. Means we have to reach the steady state plasma concentration, we give the loading dose. Delay doesn't matter if half-life is short. And this delay doesn't matter if half-life is short, we need not give the loading dose. And if there is no emergency or urgency, we need not give the loading dose. Like this half-life is 4 hours, and dose is 100 milligram per hour. Can patient of osteoarthritis wait this long? Osteoarthritis का patient इतनी देर तक wait कर सकता है कि 4 घंटे में 100 मिलीग्राम उसकी हाफ लाइफ जो है वो. So solution, use a larger initial dose. हमने larger initial dose की. This is the target concentration. So we give the target dose we given was 200 milligram. Which concentration do you want to achieve? This one. So this will be the 200 milligram concentration will be achieved. And the formula for loading dose is target concentration into volume of distribution, apparent volume of distribution. So maintenance doses, once we give the drug, we in the loading dose. Now, when we give the drug in loading dose, it will be slowly metabolized. After 6 hours or after 8 hours, it will be metabolized in the body and its levels will decrease. So, to maintain the loading dose or to maintain the steady state plasma concentration, we need to give the maintenance dose. And this maintenance dose depends upon the clearance. It is plasma concentration into clearance. That is the maintenance dose. So if loading dose is not, maintenance dose can be calculated. Like loading dose is plasma concentration to volume of distribution divided by pi availability fraction. And maintenance dose is loading dose into K, that is equivalence. And clearance can also be used to determine the maintenance dose. Like this is the graph. Loading dose we have given, slowly it is decreasing. Maintenance dose we have started, it will be increased, and so the effect can come. When the rate of drug administration becomes equal to rate of elimination, the steady state is said to have achieved. And this concentration occurs, the steady state concentration, what is steady state concentration? It is rate of drug administration is equal to rate of elimination. And the steady state is reached. And that is up to 4 to 5 half-lives, the steady state is reached. And it is determined by half-life of the drug. Like this. This is after first half-life. This is the concentration. Second half-life, third half-life, fourth half-life, fifth half-life. So after fifth half-life, it is not increasing. The concentration is not increasing. Steady state plasma concentration. So this is the how the steady state plasma concentration is reached. Thank you. That's all. I hope you understood my video. And if you like this video and if it is helpful to you, kindly subscribe to my YouTube channel, List of Nitika Pharmacology Discussion. Thank you. Be happy, be healthy, be blessed, work smart, work hard. Happy learning. Thank you. Be healthy, be happy.